Hello and welcome to episode 7 of the Geo AI podcast. I'm excited to have all of you join us today because today we're going to talk about a pilot that we are kicking off with AWS, Amazon Web Services, dealing with their Nova foundational model. We'll talk about that in a second, but I'm proud to announce that this is actually the third pilot that we have done with AWS. As a health tech firm, AI firm in the healthcare space, we are cloud native and we have been on AWS really since our beginning. And we did 2 previous pilots with them on the SageMaker Geospatial product. Very exciting, very wonderful products, pilots that gave us, and I'm sure and we hope that AWS benefited from it as well, but it certainly gave us exposure to leverage satellite data and do feature extraction on satellite imagery, which we continue to do today in a lot of the work that we do. This pilot is on the Nova foundational model. And to help me talk about it, I'm joined again by Paul Churchyard, who several of you will recognize from past episodes. Paul is our Chief Technology Officer and Chief Geospatial Officer as well. Chief Geospatial Engineer, really, I should say. Paul, welcome. And please give the audience a more complete introduction of yourself.
Of course. Thank you, Ajay. Hello, everyone. As Ajay mentioned, I am Paul Churchyard, the Chief Technology Officer and Chief Geospatial Engineer for HSR.health. I have been at HSR.health now for over 6 years, which has been a really long time, and I've definitely grown a lot in my capabilities over the course of my time here. And my main responsibilities at the company involve doing a lot of the data analytics side of things, as well as the geospatial analytics side of things, as well as developing and maintaining our cloud-based infrastructure and all of the cloud pipelines we use for our analytics and to deliver our insights to end users. Back to you, Ajay.
Thank you. Thank you. So this pilot is about the Nova foundational model. So the first thing, although many of you may know what that is, but Nova is AWS's foundational model for generative AI. It is accessible via Bedrock and the Bodo 3 API, AWS's Python library. Nova is fairly new. It was introduced recently at reInvent, which is the week after Thanksgiving every year in Las Vegas. So that's about 5-6 months ago, right? And so this is still early on in Nova's life cycle, and we're going to be looking at Nova in a number of ways. What we're going to be doing overall, and Paul, I welcome you to jump in here as well, but we're going to be seeing if the Nova foundational model as it is, which is a general purpose foundational model, fits the needs for our generative AI use cases in the healthcare space.
That is correct. At a high level, sorry,
Go
at a high
ahead.
level,
No, go ahead. Go ahead, Paul.
at a high level, what I view as the kind of main uh, outcomes or deliverables or tasks from this pilot effort, as you mentioned, is to see the viability of transitioning from GPT to Nova within our utilization of LLMs within our AI orchestrator framework. And there are two underlying components, well, 4 underlying components that we want to look at price and performance. And when I talk about performance, I'm talking in terms of accuracy, because I believe we are utilizing LLMs in a pretty unique way within our orchestration framework, where we know what the expected answer from the particular query should be. So being able to see how often the LLM is actually able to respond with that answer is going to be one of the metrics, as well as costs. And we also want to look at the performance as well as costs, looking at in prompt fine tuning versus supervised fine tuning for large language models.
Yeah. So Paul dropped a lot in that, but he's right. All of those elements are parts of the pilot, and we do have a fairly maybe not fairly novel, but exceptionally novel, we think, approach for leveraging foundational models for our generative AI. That will be the subject of a separate episode of the GeoAI podcast, and we certainly would welcome anyone who wants to have a conversation on how we do that.
100%.
Lost the screen there for a second, but it's another important aspect I think for this pilot is costs, right? There has been a lot said about the potential cost of generative AI. We certainly see the gains and the capabilities and the power these models can have when used effectively, but there's a compute cost, and it can be quite substantial. And then, of course, as the use cases for AI grow, the compute costs themselves will grow as well. So that's something to be carefully considering. Right, Paul?
Yep, that is correct. And with our current approach that we're exploring, I believe that it is a way to take advantage of the strengths when it comes to especially stuff like language comprehension or surrounding knowledge that's out there in the internet zeitgeist, for lack of a better term, to be able to incorporate dynamic text based or even visual based, depending on what foundation models you're using, into predictable programming logic, right? So the key to what I think we're trying to do with Anna is to not have it so that you have to try to get all of the functionality you want from a singular um, foundation model or a singular set of agents, but being able to expand the capabilities of these foundation models by using them in smart ways and interfacing them with other existing and well known tools like programming to get in to be able to get that additional functionality that you might want
Right.
out of your use case without having to try to really extensively train a
Right.
foundation model to accomplish the same task.
Yeah, and there on that point, we're not necessarily opposed to training a health focused foundational model for health use cases. In fact, that may very well be a long term outcome or long term need. There are some, not a lot, there are some who say that they have health focused foundational models. Our approach has been that to save the costs, the data needs, the compute requirement, and of course the environmental impact of training further and further foundational models, we can use basic foundational models, general models from any, sort of, if you will, now off the shelf foundational models with our approach for fine tuning and for using those tools to extract what we truly need from those tools for our use cases,
Yeah,
which is why we're comparing against open AIs, because of course it's you can do a lot of measures, but it may be the most popular, most widely used foundational model in the world. Whatever it is, it's certainly well known. So we're going to compare Nova to the OpenAI foundational models for our use cases, our statistics. We know how accurate we are. What we know our history. We'll see if that can be replicated with Nova and our approach. And if not, what might need to be done, whether it's a modification of our approach, fine tuning of the model, or what potential third option, and then the cost structure that's associated with the use of the Nova model versus other models. All of those are important considerations, of course, when anybody is planning to go forward with a generative AI solution for their organization.
yeah, 100%. And quickly speaking of price, well, not necessarily price, but also portability and making more use of, I guess it is price, and making more use of foundational models. That is one of the nice things about the, to some extent, in prompt fine tuning approach,
Mm-hmm.
is that you can, depending on what you really want the format of the output to be and what type of questions you want to ask, by including examples of a prompt and like an expected output within the prompt where you're actually asking the question as well can be a nice way to um, get to start fine tuning models to get the behavior and output that you're looking for. And since it's within the prompt in and of itself, it also makes it portable across different models, across different base models, that is, relatively easily, because you're not doing the more detailed fine tuning. Um, but the kind of trade off there is that you do use more tokens, but you're also utilizing the base model. So, usually, from what I've seen across different uh, base models and pricing versus fine tuned model pricing, usually the base model is cheaper because you're just using what they already have available, not taking up additional resources with the fine tuning and all of that. But it does give you that portability. And then on the flip side, once you're able to really hone in on, if you're honing in on specific tasks or specific questions that you want your uh, model to be able to answer with a lot of precision, then switching over to doing something like a supervised fine-tuned model can make sense. Because then in that case, you're able to give it more examples than you would within a in prompt fine-tuning approach.
Wow.
And each time you're
Yeah.
calling the model, you're not passing in all of the examples again, right? So you
Yeah.
end up using less
Yeah.
tokens. So there's definitely some trade-offs and stuff to consider when looking at these two approaches.
Well, there's a lot to consider, right? And we're going to do a demo of Anna on generative AI just to give everybody a flavor of it. And we're also going to talk about specific use cases, as Paul referenced, that each use case may have its own needs. But first, Paul, let's general discussion about why the base a foundational model may not be enough or good enough for generative AI use in healthcare. What are your overall thoughts on that?
Yeah, so that is a really good question. I think the biggest concern is that in healthcare, there are a lot of areas where you always want, to the best of your ability, the most accurate information because you are dealing with people's lives and any underlying conditions that they have. You want to try to not exacerbate that or make things worse. And then in addition
Mhm.
to that, you there's a lot of specialized information, for lack of a better term, within the healthcare
Critical
space.
context.
Yeah, clinical
Yeah.
context or just the names of all of the diseases, what all their symptoms are. There's just a wealth of
Medical
information
ontologies. That's
there.
correct. Yeah.
Yep, there's a lot of
Yeah.
information there, and these kind of general purpose models, which are usually the first foundation models that get out of the gate, like OpenAI, like Nova's base foundation model, they were tuned for kind of more general purpose, right? So it might be good enough if you want sort of for as an analogy, sort of like a WebMD sort of answer to a health sort of question that you may have. It can give you some nice summaries, some symptoms, or some ideas of what possibly your symptoms might be representing in terms of a disease. But in terms of implementing into actual clinical use cases or utilizing it as a part of clinical research, there does need to be more of a focus in that area, so that it's less likely to it's able to focus on that knowledge when answering questions, as opposed to potentially pulling in uh, other stuff that it might find because it's trained on just general information instead of subject specific information, in this
Right.
case medical specific information.
Right. There's also concern that general purpose or base foundational models may not be able to meet the audit requirements and the provenance, source traceability requirements that healthcare regulators demand, right? Whether it's joint commission or other particular standards that hospitals and health systems have to follow. And
Yeah,
so there may need to be a health specific foundational model created.
yeah, that's very true, and I can see that being something of concern. in kind of two main ways. One way in which it could potentially be addressed from still utilizing the foundation model perspective is if it can be addressed by how you decide to set up um, the foundation model and how you structure the prompts. Because if you make it so that the foundation model only answers questions based off of information that you've pulled from, say, retrieval augmented generation, and you make sure that you fill the RAG library that you're using with published research, accepted books,
Right.
published by doctors, and make sure that when it answers, it cites all of the documents that it
Right.
pulled. That's one way to address that.
Right, but you're stressing, and you're saying that it's one way, and it's a good way, but that is a lot of curated and validated documentation and information for the RAG approach. You can't
Oh,
just say, "Hey, here's my knowledge base, use it for RAG." It has to, you have to really understand what that documents, what that knowledge base is, and that itself is a level of effort.
that is correct.
Yeah.
And then in addition to that, it's totally understandable as with models are trying to roll out more of the um, reasoning side of things as they go through generating their answer. That's something I've seen a lot recently, but it is still difficult to fully grasp the what's actually happening under the hood to
Yeah.
generate the answers that are there, and that just poses
Right.
a general provenance
Yep.
issue.
I love that we are both having this conversation today while we're distracted, you know. It's interesting. But but it's good. So let's get on to it, right? Let's should we talk about some health use cases first or go right into a demo?
I think we can go
Maybe
right
let's do a
into a
demo.
demo. Yeah.
Let's do a demo.
So let me pull it up.
And this demo is available for users on our YouTube channel. Right.
Yes.
Awesome. If you search for HSR.health on YouTube, you'll find our channel, and those who subscribe to will get a link after the show to our channel for this and other demos. But go ahead, Paul. Set it up.
Yeah, sure thing. So with this, I have recorded a query for a disaster response use case. Specifically, I'm asking what is the health risks from Hurricane Milton in Florida at the zip code level. And so this ties into one of our suite of indicators that we have been developing relating to disaster response, where we want to look at the underlying health and social posture of disaster impacted populations so
Right.
that that information can be used as a part of the response and recovery process, as well as to prepare for the disaster as well. Um,
Yes.
so,
So this is this is currently using a non-nova foundational model. We know what the results are. We know how accurate it is. We have the statistics and performance indicators for our use of our disaster health risk indices on our current approach. We're going to replace and insert the Nova foundational model and compare, right, to see if Nova can help us achieve the same level of successful output as previously, and then of course do a cost comparison of the same. Right.
yep, that is correct. And one thing I do want to note that is somewhat different from other generative AI front ends or generative AI chatbots, depending on what you have interfaced with. Let me pause this real quick. Is that, uh, as you see, it does take a minute or two to generate an answer to your query, and that is based off of the orchestration. That is a result of the orchestration structure that we
Right.
have under the hood that brings all of these capabilities to Anna, where there is a lot of data read in, calculations, filtering, and other processes that are happening behind the scenes based off of your query and based off of our available data and the available data pipelines that we have through our cloud deployments. They're all being run to then visualize the answer to your question.
Correct. So, in essence, Anna which is our product name for our generative AI, is not really just generating a response by comparing against some knowledge base of text and of imagery of information. It is actually doing the math. So if you're asking a question like, what is the highest risk zip codes? That's requiring a calculation. It will need to know where Hurricane Milton is, where it's expected to be. It'll need to know a lot of statistical data about those zip codes within the cone of uncertainty, and it'll have to do a calculation to consider who's at the highest risk relative to the other zip codes within and near that zone of uncertainty. So it's doing math. You can think of it not just as a generator of generative AI, maybe even a generative BI, really. It's a business intelligence capacity that it's offering. So it takes a little bit more time.
Yeah, 100%. So to continue, now that it's generated the response, so one of the main benefits I view of our approach is that you get a direct text-based response to your initial query, alongside the geospatial visualizations, and with some improvements we're working on over the near future, full geospatial dashboards alongside the text as well. It allows for the bridging of the gap between just throwing a geospatial dashboard at someone who might not have previous geospatial experience and them not knowing how to interpret it,
Yes.
versus being able to get a direct text response to the question that they have, and then being kind of introduced to why or what the geospatial context surrounding the answer to that question is, right? Since we are at our core a geospatial health risk company, we do believe in the power of incorporating these geospatial aspects of disaster response, health equity, social terms of health, and health outcomes is an important part to take into consideration, and one that we
Yes.
feel oftentimes isn't as included as it should be.
Cool. Yeah. So that's where we currently have does allow for some level of user analysis and interrogation of the results. And as Paul highlighted, as we advance, the map portion, if you will be its own full-fledged analytic dashboard that will allow a user who has the experience or has the interest to truly slice and dice and analyze the data. But if a user who does not necessarily want to do that themselves will continue to be able to have a chat conversational prompt-based interface with Anna to do that analysis is sort of automatically or sort of through the system itself.
100%.
Cool. Thanks, Paul. And there are other demos that are available on our YouTube channel and more that are planned for anyone who wants to see how Anna currently works and what Nova will be doing, what we will be doing with Nova.
Yeah, definitely.
Now for use cases, right? So the idea is, and we've seen a lot of this in the media recently, right? In the technical press, that generative AI can do all these great things, but it's not necessarily clear what actually uses Gen AI in a way that achieves a near-term positive ROI, right? So in healthcare, what kinds of use cases are we seeing, Paul?
Yeah, definitely. So some of the more traditional use cases, that might be a bit outside of our scope, just based off of what we do, is looking into like voice transcriptions, transcribing doctor's notes, right? Trying to kind of make that patient clinical interaction with the
Right.
patient side of things a bit more
Yeah,
easy,
you're
a bit
talking
more
about ambient
streamlined.
listening.
Yeah,
Yep. Ambient
100%.
listening is very popular. Most hospitals want to do that at some level. Most clinicians want to do that so they don't have to be entering text or they don't have to be entering data into a form. They can talk to a patient.
Yeah,
That's certainly a
100%.
very good use case. But and in other use cases that are sort of more on the analytical and hospital level operational perspectives are things like distance to care, right? Where health systems, insurers, health agencies, health departments can assess the level of distance and therefore the accessibility of healthcare facilities to their population, whether the full population of an area or the employee base or the covered the insurance companies that covered populations, right? They can see how accessible really are the healthcare services that are made available in an area.
Yeah, and with distance to care being intrinsically a geospatial sort of analysis, um, us having the ANA interface to kind of once again bridge that gap between geospatial and text is a good way to be able to convey that sort of information and those insights. And additionally, on the distance of care, that's usually only one. When you're looking at the totality of impacts on uh, a person's health, distance care is only going to be one factor at play. You have all of the
Yeah.
surrounding social, environmental determinants of health that are at play as well, based off where they live, where they work, what their commute's like, um, as well as the prevalence of underlying chronic conditions from zip code to
Right.
zip code. And so being able to overlay all that together into a complete and coherent analysis um, can be
That's
challenging
important.
to interpret.
Exactly. So there's a couple of levels there, right? First is to really understand what the social factors are in total that could be influencing outcomes in a region or for a population. And then second challenge is to acquire the data that represents the various factors, right? Social, environmental, population dynamics, etc. Right? You mentioned transportation, housing is and food security are others, but there are a plethora of factors, tree coverage that will indicate potential allergen sources, right?
Yep, 100%.
And then it's layering all of it. Yes, geospatial technologies enables that, but it's not necessarily always easy to do in a way that can be visually seen, right?
Mm-hmm.
But then the bigger challenge, interpreting it and analyzing it correctly. Anna allows non-technical users to ask questions and allow the machine, allow the system, allow Anna to do the work.
Yeah, 100%. That's one of the main goals is, again, to make the extraction of insights easier. And to also, once say you've looked at the data through Anna and then figured out as a part of your data science team, or we figured out based off of our subject matter expertise, um, uh, algorithm to be able to quantify the question that's at play, right? Whether it be what factors contribute to um, underlying health conditions, uh, whether distance to care plays a role in 30-day readmissions, right? Or looking at the impacts of or the health posture of disaster impacted populations. All of that is able to be coded into these data pipelines, which can then be automatically triggered, and data from the results from those can be retrieved and displayed through ANA as well.
Yeah. So those are some of the use cases. Of course, there's no real limit to use cases. And of course, the biggest thing, the first thing place to start is to understand what is a potential organization that wants to consider generative AI? What are their challenges? What do they need to accomplish from a business strategic perspective? And then figure out how generative AI may enable them to meet those strategic goals. But what we've talked about with respect to care accessibility, with respect to what factors are influencing care outcomes, those are certainly, and of course, ambient listening, those are certainly very good, very commonly used use cases and starting points in healthcare for generative AI and for AI in general.
100%.
So as we start to wrap up, Paul, one of the questions, obviously, something that people are interested in, what is what is the current status of the pilot, and long term, what should people who are interested in the outcomes, what should they expect in terms of what we share publicly over time?
Yeah, sure thing. Those are great questions. So we have, there recently was a blog post published by AWS, kind of signaling the kickoff of the pilot. And we have uh, members of our team working on the tasks of doing the in prompt fine tuning and starting to go through some of the training data that we already have for some of the specific functions that we're using. So we're already gotten started on some of the work surrounding the pilot and getting into some of those comparisons. And coming down the pipe, we do expect to have at least a white paper, right, describing kind of the results of the analysis and talking about how the LMs are utilized at a high level within our orchestration framework and what the vision forward is for either the inclusion of Nova or GPT within our orchestration framework.
Or other model, right? There's no, when once you start looking at models, there's no limit to maybe potentially considering additional models. And I think that as we have findings to share, even preliminary findings, we will be open to discussing them. So anybody's interested, please reach out at impact@hsr.health, sign up for our newsletter, and you'll get updates on where we are with the pilot and our next steps in that effort. We do anticipate having a pilot wrapped up in 3 to 6 months, hopefully closer to 3 than 6, and that is certainly our goal and intention. As Paul mentioned, work has started. Of course, we're taking very seriously the documentation and the planning stages of any pilot. So that work will be completed very shortly, and then we'll get things going. We are very excited about this pilot. I think I'll say for everyone on the team at HSR.health. So we're really going to be paying a lot of attention to the progress on a day-to-day basis.
Yeah, I'm excited to see what the results are.
Cool. Any last thoughts, Paul, before we wrap up?
Uh, I don't think I have any, but it's been a pleasure as always, and I really enjoyed our conversation and being able to talk about what we've been working on relating to Anna and the Nova pilot.
Thank you. Yes, Paul, thanks for joining me, and have a great short post-holiday week, everyone, and stay tuned for future episodes of the GeoAI podcast, and updates on our AWS Nova Foundation model pilot.